So again, preventive care grand rounds, and we are going to talk about global health and non-communicable diseases. I did this presentation because Dr. Johnson from the Global Health program here, Mastering in Public Health and Global Health, invited me just for the fact that they are getting a little concerned about NCDs, and I'm going to mention NCDs from now on, in other countries and even in our countries in different ethnicities and levels of socioeconomic status and around the country. So far, we divided diseases according to demographics, meaning that low socioeconomic countries or areas will have more infectious disease. And then nobody paid much attention to the non-communicable diseases until a few years ago that the World Health Organization have checked those things. And then changes have been happening all across the world. I remember when I was working in Brazil, I was a physician there for 14 years. And then when I finished my medical school in Brazil, and this was old, in 1978, one of the major causes of death in the world was, and even in Brazil on that time, was diarrhea, maybe because of cholera or other parasites or whatever infectious disease, salmonella or related disease. But today, if you go to my country, Brazil, the main cause of death is heart disease. In fact, the main cause of death in all countries in South America, Central America, and North America is heart disease and stroke. So we have a change of the profile, and then this shows that many countries are now having more diseases that belong to the developed countries. And then the reason for that is that many countries are becoming developing countries. And that's the challenge that we have today. So I'm going to go over the presentation and we will talk more about that. And we will have time for discussion along the way. I was in my church one day and there was this mission trip to, I think it was Africa. And then the students that were promoting that, they were asking for money, and someone asked, what is that you need money for? We thought that was for their expenses or trip expenses. They said, no, we want to buy candies and chocolate for the children. And then they will get to the mission trip and then they will attract their parents. Well, I was a little concerned about that. And I said, well, why don't we give something else to the children, like balls or some other things, not candies? And then it generates a little bit of a discussion on that. So if you don't give candies, we don't have the children. And if we don't have the children, we don't have the adults. But I've been to at least a few health mission trips, and it is easy to attract children. I remember one of our trips to Brazil, to Amazon, we just sing with the children. We have a person that was playing the guitar all the time and playing children's songs, and the children follow us all the way that we went. And then, of course, their parents come after. So it's not that hard to attract the children. I don't believe we need to use candies. And many people say, well, is that a big problem? Well, it is a big problem when you consider the principles of that. So you don't want them to go from a transition that they call epidemiological transition from infectious diseases to chronic diseases. So as soon as they get out of their profile of diseases that are infectious, they got to diabetes, hypertension, cholesterol, and heart disease, and we don't want them to go on that direction. Or at least we should do something on that. By the way, many developing countries are now facing a double burden of diseases because they still have a high level of infectious diseases, and I'm going to show some numbers here. And then they have the burden of diabetes, hypertension, cholesterol, and cancer on the top of their infectious disease. So the situation is getting very complicated for them. Let's take a look on what I call world McDonaldization. We have seen McDonald's everywhere in other countries. This, I believe, was in Nigeria. And so we have McDonald's in China, no doubts about that. And I have a report, an interesting report that I have to share with you. I used to work in Hong Kong for 6 years, and then I visited several places around China. And then one time, Dr. Frank Hu is the director of the Harvard nutrition program, and I believe he's somehow he was the director of the Harvard School of Public Health. And then he went to Hong Kong and was giving a lecture for us about childhood obesity. And then he told us a story that was very interesting. He was in Beijing, and in Beijing he was talking to the communist leaders and authorities on that part of China about the epidemic of childhood obesity. And then he said, because you are westernizing your type of food, and you are westernizing your restaurants, and you have McDonald's, Burger Kings, and Kentucky Fried Chicken, KFC around, your children are becoming very obese. And this is getting to epidemiological concern, because you are going to have a toll of diseases if you don't curtail this. So my appeal is that you start developing more local types of restaurants, or try to influence the Western restaurants to go on the local types of food, because the epidemic is already in Beijing, and Beijing is becoming a capital of childhood obesity. So what happened is that after the meeting, the communist leaders surrounded Dr. Frank Hu and told him, hey, are you sure about that? Because we came from a period that we didn't have enough food in this country. And famine was very popular, very frequent. And now that we have an opportunity to have more restaurants, more food, more outside food, more Western food, so we think we are progressing. And they tried to convince Dr. Hu that the problem was not that, but it was a hard time for him to convince the leaders that the problem is the type of food that they are consuming. This will create an epidemic of diseases, because childhood obesity will come with consequences that we already know, as diabetes, hypertension, cholesterol, heart disease, and stroke. So this is a picture that I got from China, I got from the internet. But I hope this boy is not drinking what is in the shelves in his bottle. But continue the McDonaldization. So India has a hard time with this. Even though many restaurants, McDonald's restaurants in India, they serve vegetarian foods, is not the best kind of vegetarian food, maybe rich in other things. And they are very concerned that the Western restaurants must need to start offering healthy options for them, because the situation in India with diabetes is getting very complicated. So this is a McDonald's restaurant in Hong Kong. In Hong Kong, we can see from one restaurant in one street, we can see the other McDonald's restaurant in the same street. I took this picture when I visit there. After I finished working in Hong Kong in 2007. So in 2015, I visited and I took this picture. So this is a picture in Romania. I took that picture also when I went there for a health trip. So it's interesting because in this picture here, let's see if I can put the. So yeah, you see the banner of the. It might not work as I was thinking, and so. I cannot find the, yeah, I found I have to edit this later on, but I want the laser point. So you see here, this is in this is the parking lot for the McDonald's, and you see the banner of the country here, and besides that we have the McAfee, the McDonald banner, and then we have a big screen with a Big Mac being advertised in this central area of the country. This one is in Brazil. So we have, if you can pay attention how many people are in front of the ice cream park. Sorvetes mean ice cream. But they have here the combo for one hamburger, French fries, and a Coke is about $8. $8 would be $8 would be about $1.50. So it's very cheap, and they are saying that the price by show means that it went down. So they are trying to convince these people that cheap food is healthy. One is in Ecuador. In Ecuador is interesting. Ecuador is a kind of a socialist country, and when I visit there, I was surprised that they use they are socialists. They are not into United States that much, but their money there is dollars. They use the same dollars that we use here. So you can see that for them the menu of is a little more expensive than Brazil. But a Big Mac, a serving of fries, and a Coke is $4, $3.99. The same price. I think here is more expensive. I don't know how much it is, but I believe it might be double of that in the United States. So concern here is not that I am against McDonald's, so don't take me wrong. I am not against anything in terms of brands, but I'm against the principle that we are selling junk food to these populations, and this is the situation that is happening now. In 2016, we have 1.9 billion adults overweight and 650 million obese. 39% of adults 8 years old are overweight, and 13% were obese in the world. And then if we compare to the amount of people that are undernourished, we are maybe 3 times more obese people or overweight people than the undernourished that is 690 million. I remember about 10 years ago that we have 1 billion people that were obese, I mean overweight and obese, and then we have 1 billion that was undernourished. Unfortunately, or fortunately for one side, we decreased the number of undernourished. So now we have about 700 million or 690 million. But on the other way, on the other hand, we have 1.9. So we increase 900 million adults with or people with obesity. But the worst of this situation is not just the adult population, the children. Most of the world population live in countries where overweight and obesity kills more people than underweight. So we get to this transition in many of the countries, but the concern here is 39 million children under the age of 5 were overweight or obese in 2020. Can you believe that? We have 39 million children overweight or obesity. Over 340 million children and adolescents age 5 and 19 were overweight and obese in 2016. So, okay, it's still less than the number of that I mentioned before. If I can come back, yeah, I mentioned before that 690 million are undernourished, but this is not children. This is the general public, and then we have now we have 380 people that are becoming obese in these populations. This is a concern because the number of undernourished is going down, but we are substituting kwashiorkor with obesiorkor. Obesor is a name that we don't know. We don't have this name. Okay, don't charge me on that. But that's the transition that we have seen in the world. We have 340 million children and adolescents overweight, and then 124 million living with obesity. And we are talking about children and adolescents. So we are creating a different kind of population in the world. And if we don't pay attention to that, we will have a pandemic, not of COVID-19, but a pandemic of obesity in the world if we continue growing those numbers. That's why it's important for us to be concerned about that. That's why it's important to be concerned about bringing candies and cakes and donuts to this population in our fast food restaurants to sell our style of eating to these developing countries in the world. So if we go and check the population, the top 25 countries with obesity rates, here we have Kuwait and United States. Those are, I would say, maybe those are developed countries. I'm not sure about Kuwait much, but I know about the United States. I mean, 36% of the population is obese. But then after that, you have Jordan, that might not be a developed country. And then we have Saudi Arabia. It looks like it is in the high-income countries, very rich in very high level of obesity. But then we have Qatar, Libya, Turkey, Egypt, Lebanon, that are not developed countries, that are still on the way to get up. And they are still one of the countries some of the countries with a higher level of obesity. And then we can see down there Mexico, Mexico, Argentina, Chile, Dominica, Uruguay, Syria, and that are also high level of obesity. I am happy that Brazil is not in the highest list. Brazil rates of obesity are around 22%, but it's growing. It has grown and is a concern in the country, as is a concern in most of countries that become developed. As soon as the country start going from agriculture to industry, they start increasing the level of obesity. As soon as they come from industry that is manual industry to online or computer-operated industry, the levels of obesity increase more. So it looks like this is a disease of our progress, a disease of our more modern and scientific world. And then I'm going to concentrate in the United States to show what happened in the United States, what is happening here, and then what can we do for that, and open the discussion for that, what can be done for this. So as you see in this map here, the countries with 35 to 40% of obesity are in the southwestern, some in the northeast here, like Michigan, but most of them is the belt of obesity: Kansas, Oklahoma, Arkansas, Missouri, Alabama, Louisiana, and Texas. Those are the belt of, in Tennessee also, in South Carolina, but mostly the southwestern state. So the champions here are Colorado, then Washington, D.C., I believe is Massachusetts here, and then Hawaii. And so you can wonder if Hawaii is good, because they have high opportunities to exercise there. But and then we have California here, where we are now, that is 30 to 35%, not as good as Colorado, that is less than 25%. So we are going to discuss what are the factors related to those rates in terms of developing solutions for the problem. The main obese state in the United States is Mississippi, with 39%, 39.7%, almost 40. Maybe as I am speaking, they are already 40%. The least one is Colorado with 23.8%. So what are the reasons for those differences? And that's what are things that we are going to consider here. It might be income. There are more people with lower income level in the obesity belt. I'm not sure if they use this term obesity belt for the southern states. I'm sorry if I am using that. It's not to make fun of anybody. And it's just because the southern states concentrate the amount of people with higher level of obesity. Well, it might be because they have more food stamps, and then food stamps are synonyms of bad food stamp. People eat more fat, more sugar, more refined foods. I remember one of the statistics that was one of the research that was made with the Pima Indians in the United States. The Pima Indians were divided by a border between Mexico and the United States, and their tribe was divided in the Pima in Arizona and the Pima in Mexico. And then was interesting that the Pima in Mexico, they have low rates of obesity and diabetes, and they have more diabetes than the local population, showing that maybe there is a genetic profile for diabetes type 2 on that population. But the rates of diabetes and hypertension and obesity in the Arizona Pima were much bigger than the Mexican Pimas. So one of the conclusion of this research is that the Pima Indians in Arizona, they get food stamps. They get subsidy from the government. And then that was the problem. In this subsidy, they get more meat, sugar, and fat that they used to have in their traditional diet. Of course, there are other factors. They are not doing much their dances. They are not doing much their hunting, and they are not, of course, eating their foods, the local or traditional foods they used to. Other factors that are related to obesity would be unemployment and general income level. So if you go to the southern states, you most likely will see these promotion here. Large greasy cheeseburgers. We don't have this in California for sure, and we don't have those in Colorado. I am sure about that because my daughter lives in Colorado, so I have been to Denver several times and I never see a sign like that. So other factors that might be related here are cultural choices, like the type of foods that they serve in the southern states might be related to more fried things, deep fried things. You know what a chimichanga is? It's a burrito, deep fried burrito. So they are not happy with the amount of fat in cheese and meats and mayonnaise that is inside of the burrito, but they have to put more fat and deep fry it. Another fact would be African Americans' race. The rates of obesity is much bigger in African Americans in Mississippi and in the southern states. So there is a factor related to that. I'm not sure if this is related to a race itself, but maybe, or ethnicity itself, but maybe is related more to social economic status. I mean, if they are not able to buy the produce and whole and healthy whole grains and healthy foods, they might be more of a target for obesity. And then is related to the third item here, availability and affordability of healthy foods. So the price of these healthy foods might be high, and in some places even they don't have the food, where they have food deserts that you don't have grocery stores there. And we don't need to go to the southern states to see that. You just go to San Bernardino. One time we did a research, a survey, a surveillance in San Bernardino, and we found that in San Bernardino City, they don't have grocery stores. Well, they have grocery stores, but no groceries sold in these stores. The stores just have something canned, packed, and then a lot of sugar things, a lot of unhealthy foods, and they don't have fruits and vegetables there. So that's one problem. And then we go to opportunities for exercise. That is a major factor, and we will discuss this in the next slides. And then health education, health literacy, and then access to health care. I put a big exclamation or interrogation point in health care because is this a problem for chronic disease? I don't believe so. But I believe the access to healthcare is related to health literacy and health education. People that have more health education, people that have health literacy, are people that can afford to have healthcare and not healthcare directly. Because I don't believe that healthcare is a determinant of chronic disease, because chronic disease factors happen before you have access to healthcare. Access to healthcare is to treat a person with obesity, hypertension, and diabetes, but not to prevent those diseases. But I still keep those there because they might be related to affordability and then an education on prevention too. Have you seen a place like that, a food like that in Colorado or California or in the Western states? I don't think so. This is very common in the Southern states. You have a donut, cheeseburger. Let me start again. You have a deep fried donut cheeseburger. You have a deep fried donut cheeseburger. Where can we find something like that? I mean, then is something common in the southern states. But the real secret is exercise. The CDC did a study that is in this website here, and they compare states that do exercise with states that do not do exercise. So they found that the states with more rates of exercise, with aerobic exercise and strengthening, fulfilling the 150 minutes of exercise per week and at least two times of strengthening exercise per week, Colorado was the top one. The national average is 22.9% of people in these countries doing the exercise. And guess what? The lowest level was in Mississippi, 13.5%. We have a map that I'm going to show you next. But just to compare those two here, you see the highest obesity state in the country was Mississippi, and the lowest amount of exercise in this state. The lowest obesity state in the country was Colorado, and it is the highest exercise state in the country. Let's move to the map now. It's almost the same map that I show you with the obesity rates. Do you remember those? Yeah, you see that we have the obesity belt. Sorry about that again. But with the exception of Georgia and Florida, most of these states are the obesity states. I believe they include Louisiana and Texas. But even Louisiana has less than the average of 22.9%, the national average. Texas was doing good with a little higher than the average, but it's still under the 30 level compared to Colorado, that are the champions here. Even Florida, I was not believing that Florida, a state that should be like Hawaii, but I still have a lower level of exercise. Even Hawaii is not that good, I mean, with 24.4 rates of exercise. But it still is something that we have to consider. Exercise as the big differential here when you compare to states in the mostly the Western that are 30 or close to 30% of people doing enough exercise. So now let's check a little bit, change a little bit to the world, and you see that the leading cause of death globally are related to diseases that are predictable or preventable. So what they call non-communicable disease. All of these blue dots here are diseases that are, I would say, not 100 preventable, but almost 100 preventable. So I will repeat those just in case. Heart disease, ischemic heart disease, stroke, chronic pulmonary disease that is related to smoking, and then lung cancer related to smoking, Alzheimer's disease, diabetes, and kidney disease. And those are diseases related to lifestyle. I can tell you, my father died of diabetes, and then he was when he was 65 years old, he died with complications of diabetes. One of my, all my family from the father's side is diabetic. So my uncles and my aunts are, and those are 6 or 7 of them, all diabetics. And my oldest uncle, he is about 86 years old, survived my father that died with 65. But my father was obese. My father used to smoke. You know that smoke and diabetes are related. He used to eat whatever. He was not into exercise. So he didn't take care of much. My uncle that is 85, he is taking more care, but it's still one of the problems that I called him this week, and he is with chronic kidney failure. So he might go to dialysis now because of his diabetic condition that affect the kidney. According to the World Health Organization in 2021, NCDs kill 41 million people each year, and those are 70% of all deaths globally. So we can tell people very clear that we have to be concerned about deaths and about non-communicable disease, much more than we are with communicable disease, because 70% of deaths are caused by non-communicable. So this is my argument for those that are doing mission trips, global health guys, that hey, the world is becoming chronic, sick with diabetes, heart disease, and cancer, and hypertension. We have to pay attention to that. Each year, more than 15 million people die from non-communicable disease between the ages of 30 and 69 years old. And these 85% are happening in low and middle income countries. And I am not reporting here the factors that we call years of life lost. So if we get this population with 30 and 69 years old that didn't die, but they cannot work, or if they work, they cannot perform well in their work because they are sick with diabetes, hypertension, chronic disease, okay? So it is a big toll on a population that should be producing more, but now they are disabled. 77% of all NCD deaths are in low and middle income countries. So diseases are being exported from the Western countries to the under or low and middle income countries. And that's one thing that we have to pay attention. Cardiovascular disease is the main cause of death in the world. About 18 million people die every year because of coronary heart disease and other heart diseases. That could be a big percentage of this disease could be prevented. And that's something that we cannot accept, that people are dying from diseases that we could prevent. And then cancers, 9.3 million people are dying from cancer. And it's still in these countries, they are increasing the amount of smokers. They are increasing the smoking industry. Fortunately, in our country, we are shutting them down. But are we shutting them down or we are exporting them? So it's a question for you to think. Respiratory diseases and diabetes are also in the other cause of death in the developing countries or in the world. The four main factors for this increase of non-communicable diseases are tobacco use, is still the main one, physical inactivity, harmful use of alcohol, and unhealthy diets. So we didn't talk much about alcohol, but many people are saying, well, the Europeans saying that drinking 1 cup of wine per day, you prolong life. And that is a myth that is already debunked, because it's not like that anymore. The World Health Organization is saying that, hey, alcohol will lead to harmful use of alcohol. Wine will increase if you let it alone, and then it's gonna be a burden for the countries. The most countries that drink alcohol in the world are the Western countries, like United States, European countries, United Kingdom, and South Africa. Those are the ones that consume a lot of alcohol, and those are the ones that have a lot of burden because of alcohol use in terms of liver cancer, breast cancer, stomach cancer, esophagus cancer, and then even diseases that are not related to cancer are increasing. These, like accidents, are increased geometrically. And so maybe geometrically is not the term, but the diseases are increasing so much great in these developed countries that the World Health Organization is telling them is telling the developing countries, hey, you better curtail your use of alcohol now, because you are going to get to the same level of diseases that we have in the developed countries. Is not a joke. Don't go with the idea that drinking moderately is good, because drinking moderately will lead to drinking hardly. And we don't want to get you in trouble with that, because it's a burden of diseases, and also is a burden of monetary or money in the country. So let's take a look on some profiles here. Brazil. This is one famous statue in Rio de Janeiro. You see in Brazil, the main cause of death is heart disease, and then the second is infectious and parasitic disease, and then the third is cancer. You see that in the first three, you have a mix of chronic disease, non-communicable disease, and infectious disease, and so the burden in this country is double. But the main cause of death is still heart disease. So if you go in Africa, you see that most of the diseases are related to childhood conditions, neonatal conditions that kill most of the people. The second is infectious disease. But if you go on here, let me go with my cursor here. If you add stroke and heart disease, you put this circulatory disease in the second place here as the main cause of that. So again, in Africa, most of Africa countries are having a double burden of diseases with neonatal conditions related many with infectious disease and respiratory diseases that are infectious, with heart disease and stroke that are clearly non-communicable disease. So I went to Southeast Asian country, and I have the same burden. The burden of chronic disease is taking over, as the main cause of death in these countries are ischemic heart disease and stroke, as you see here. And those are the main cause of diseases. And we even don't have in that country anything on infectious disease until we have to number 12 as risk of the main. Well, maybe I'm wrong. The lower infectious diseases are high in this country also. But we know today that many people that have infectious disease, respiratory disease, and die are the ones that have comorbidities like heart disease, stroke, chronic kidney disease, liver cancer, or other cancers, Alzheimer's, cirrhosis, diabetes in general. So those are the diseases that increase the risk of death for respiratory disease anyways, or respiratory infections. Just in a few minutes, I would like to have more time for discussion, so I will mention these very fast. Those are the distal cause of diseases that they predispose, that they are factors that are far away from the cause of disease, but they influence that, like environmental, institutional, social, economic, political, high density population, education, and lack of access to health care. Proximal cause of disease are still the ones that represent the vulnerability of the disease immediate, like poor diet, physical inactivity, tobacco use, excess of alcohol consumption, risk behaviors like sexual risky behaviors, and maybe stress and anxiety and depression are more related disease. So with this in mind, I want to finish with this discussion here. How can we affect the non-communicable diseases in the world, or in the country, or in the states here, with this approach of distal and proximal ideas? I will go to the next slide just to end it up this session and go to and finish my my share screen in order to discuss this with the audience. My last slide is a verse of the Bible that say, "Religion that God our Father accepts as pure and faultless is this: to look after orphans and widows in their distress, and to keep oneself from being polluted by the world." When you look for the people that are suffering in the world, the poor, the widows, we see that they are suffering now, not because of lack of food, but because of lack of good food. And then also because of excess of alcohol and lack of excess of smoking and lack of exercise. So still, if you want to work for these populations, you have to work somehow to provide those benefits for them. So let's stop sharing now and go to that discussion on how to address those issues when you go in a mission trip or when you do locally, how to address those issues, those distal and proximal issues in those communities. So now the audience is open. We have about a few minutes. We can continue working if you are open to that. But let's talk about if you have to go to Africa and then we go to a country and then you have a problem there that they have many diabetics there. What would be your idea of implementation, program implementation for a country like that? I think Abel would be able to say something because he was working in Africa one time.
Dr. Dos Santos and audience, that is tough because in my time when I was there, there was only one person with the diabetes type 1. It was a terrible struggle for him to get the insulin. However, I've seen the change. When I was there in 2011, I had like I would see like 3 patients a week with a problem with obesity or diabetes, or obesity or diabetes. The rest were hypertensive patients, a lot. And when I went back in 2013 to 14, instead of seeing 3 patients a week, I would see like around 7 every day with diabetes. Because in the reconstruction of Sierra Leone, a lot of Western food, the diet was Westernized. And that would tremendously increase the number of diabetics and hypertensive patients. And because it's cheap, the food, so they couldn't afford to have a decent, healthy food. So the numbers kept on increasing. I tried to educate as much as I could the staff, and every time they came to my practice, I even put a big board on my wall so I can show them, teach them how to address the issues of unhealthy diets properly, and they took notes and stuff. But we don't know what is the effect at the long range. But I guess most of this is driven by economic reasons. And the other thing I wanted to comment about, Dr. Dos Santos, is the difference between the Pima Indians in Arizona and Mexico. The history goes back years in time when the Pima Indians used to live a peaceful life. They had their crops by the river. When the other group of people decided that that they wanted the river, the waters of the river, because they wanted bigger crops. They deviated, or they rechanneled the river to go into another direction, leaving the Pima Indians without the water resource to continue their crops. In compensation, the government sent trucks bringing sugar and sugar cereal and butter and cheese, to the yellow cheese, to supplement their food because of what they have done. And with time, they started getting into obesity and diabetes. As a matter of fact, what they believe now is that they think that anytime they will get diabetes. I saw the documentary of one of the Pima Indians, became a physician, a doctor that is working there, and he's receiving a young patient, a 16-year-old patient. And then he asked him about diabetes, and then he said, yeah, my dad, my brothers, my sisters are diabetes. And what about you? He said, oh, I don't have it yet. So they're basically expecting to be into that, you know, I would say subculture of diabetes. So I think as a public practitioners, we have a big task ahead to re-educate the people and ourselves, of course.
Yeah. One point here is related to policies and influence at the government level. And that's what is important for people that work in global health, to be aware of the situation, because if they go on these countries and then they have no idea what is happening there, and they go with the flow, promoting clinics to treat those things, just sharing medication. I will tell you, I gave up on going in mission trips because my trip was just giving pills. And I say, well, I don't like to give just prescription, and boxes of pills, and say, okay, I'm fed up with that. If I cannot do better than that, I better not doing that. But what I'm saying is that for people that work on those levels, they should be aware that the influence of the government is big, that they should start with promoting more gardening, subsidizing more healthy foods than junk food, and then increase taxes on junk food. All of this can improve at a distal level, because sometimes we are too concentrated on the client itself, but we need to have a support from outside, and those are some of my ideas. Razaz raised her hand. Please, Razaz, if you want to say something.
What I want to say, adding to what you mentioned and Ebal mentioned, I feel first, before we go to a mission trip, we need to study that country, that area, assess their need, look what they're looking for, build a strategy that we can use to assess their needs. What Abel did, it's amazing that he tried to help the community there, but I feel we have to start with step one, which is, you know, study, do more research about the area, assess their needs, see how we can help them with the resources that they have in the area. So for me, if I'm gonna go for a mission trip, first step that I'm gonna take is read more about the country, read more about the area that I'm trying to serve, how I can help them, how I can assist them based on their services or supplies that they have in the country. Thank you.
Thank you. Thank you very much. You remind me about the last preventive care grand rounds when Dr. Kathy Holmes was talking about her work in her mission trip to Mexico, that she would have clients coming to their clinic with 500 milligrams of glucose in their blood without taking any medication and without having symptoms. And then how can a person survive with 500 of glucose in their blood? This is what is happening. If you go to Mexico, you have to know the profile. One time I have a visit of one physician from Ensenada. She was a professor in the School of Medicine in Ensenada. And then she mentioned that whatever she does to the patients, whatever is the cause of the patient coming to the hospitals, they come already with a triad. They come with obesity, diabetes, and hypertension. If they come because they have an accident, they already have obesity, hypertension, and diabetes. So whenever you treat the profile of a client, if they come for depression, if they come for an accident, if they come for an infectious disease, if they come from COVID, the guys come with these three diseases together. And that's why it's important for us to understand what is behind that, what is that is causing this disease, and then act or do our best to do the best that we can to prevent those. Esther, you have a question. Go ahead.
Thank you, Dr. Santos. I had a question for Abel when he spoke about the people coming into him and they were, the change in the restaurants when the restaurants came in. Do you find that the persons there, are they eating out a lot or are they preparing the foods at home?
Okay, they started eating out at the new restaurants. They're popping up. They were popping up all over the place.
Okay.
Besides the this issue of using the palm oil for food, a very heavy oil that is used for biodiesel. Right. They were using that to cook at home, and I visit some villages that they were exactly doing that because it's a lot cheaper than they could prepare themselves the oil. Actually, I had a collateral damage on that issue because they were cooking or preparing the oil on the open field, and the kids that were playing around, I received many burned kids that they fell into the container that were with hot oil. So yeah.
Thank you for that. And my suggestion then, as we're going out in the fields, my suggestion then would be to have either a dietitian, because nutrition education is really important. So I believe that teaching them how to prepare the local foods that they are using.
That is idealistic, and when there are resources. Just to let you know that in West Africa, not only Sierra Leone but Liberia, Guinea, Senegal, Burkina Faso, all of those countries, you can barely find a doctor within what would say, kilometers around. You cannot see any doctor. What you find is CHOs that had some preparation as health practitioners, and that's it. If you want to find a nutritionist, probably you'll find one or two in the whole state. So that is very difficult. Honestly, that's a big challenge.
Yeah, I think the solution or the best application on that would be training the locals. So one dietitian could go there in a mission trip and train the locals to what is good. Agree. But again, don't think that just the practitioners will solve the problem. They need to have a little more structure in the country and they may need someone to tell them to go back to their culture of eating, because their culture is much better once they have food, is much better than what we are offering from the Western. Like, I just want to share what happened in Brazil. Brazil is still not in the big level of obesity. Why? Because we are still strong in agriculture, and our food from the fresh food is relatively cheap. So to eat in McDonald's, when I was in Brazil, I came from Brazil 25 years ago. When I was there, it was expensive to go to McDonald's. I mean, this was not for the low and middle class. This was for the high class. Was a kind of a status, going to the shopping mall and then eating McDonald's. And then because of that, we still keep the beans. Brazil was a few years ago. Brazil was awarded as the main consumer of beans in the world, and that was the secret of their health, or at least to contain a little bit obesity. But one of the things would be to educate people and educate authorities to promote these local foods that are healthy, and that would make a difference at a level, a little distal level, because we see that the local level is very limited. If you tell a person to eat healthy food, but if they cannot afford, or there is not available, it doesn't help. Anyways, anybody else want to say anything else? If not, I'm going to continue talking. But when I give this lecture, there was no much response from the areas of health, because one of the problems that we have is that we compartmentalize our public health. So people that are in global health are not preventive care people. People that are in health education, that they are more in sanitation. They are not prevention. They are not into nutrition. And then when we have these silos, as Abel mentioned in the beginning, even inside of public health, we cannot communicate the messages across. I remember I was in a session in the American Public Health Association. That was in San Francisco. And then we have those ladies, two ladies talking about access to health care. And they were people leading the association on that. And then when I saw them outside, they were smoking, and then I observed they were very obese. And then I said, okay, what help can access to health care do to these ladies that are smoking and creating lung cancer and are obese and creating diabetes? Maybe it will help, but to provide more metformin for them. But it shows that the problem is more than just the clinical part. It has to be a more broad that will involve authorities, involve distal systems, and that the non-government organizations also should pay attention to that. That bringing doctors to those countries just to prescribe pills is not the best strategy. I'm not saying that is wrong. I'm saying that is not the best strategy. And as Esther mentioned, maybe those teams should be more populated with dietitians and preventive care specialists, lifestyle medicine specialists, exercise physiologists, and people that know how to help people to stop smoking and drinking and things like that. More on the broad issues that address the causes of the problem.
Yeah, that's true, Dr. Dos Santos. we need to have a very comprehensive type of program or integral. Like, I don't know if I told you that I was working with the Mandingo tribe in northern of Sierra Leone, where you don't have any medical care at all. Two of my friends, because I was a friend of a chief in the Mandingo tribe, they died, pregnant women died on the way to find medical care just 15 minutes away from their village. So I told to the chief that we should work together on teaching them, like, you know, including farming, education, especially in malaria, because kids under 5 die every day in my hospital. 3 children died average daily because of malaria, and on the weekends it would double the number of deaths every day. So because they grow only rice. So we need to teach them how to feed properly. We need to help them to understand what diseases can kill them, like typhoid and malaria. And if they don't have proper care in pregnancy, they also die. And other things that require education and basically change their paradigm of seeing things around. Because they don't get help from the government. The government receives billions of euros every year, and that goes into the pockets of the politicians. And the Red Cross, there's nowhere to be found. They also receive money that you don't see.
Yeah, well, I think we finish our discussion here. Good talks, good ideas, and let's keep it in the positives. That as much as we can, we have this in perspective that we need to help people more into their lifestyle, and understand when we see a person what is that is behind this, not just their behavior, but the factors that influence that, and see how can we, as we understand that, influence in our level, in our maybe proximal level, what can we do for that? Thank you very much. I will see you next time with our preventive grand rounds. Bye-bye.
Thank you, Dr. Santos, for the invite.
No
Thank
problem.
you. Bye-bye.
Yeah, you are welcome. Bye-bye.
Bye-bye.